Bismillahirrahman. Diabetic retinopathy, OCT. Basic interpretation of patient include a very important macular scan, the volumetric macular scan. Why this scan is important? Because it gives you information about the macular thickness and volume. Both values are very important in follow-up of disease progression and follow-up of the therapy. Any volumetric scan will present you this figure, which consists of the 9 TETRAS region. It consists of 3 concentric rings, the central foveal ring, then the parafoveal ring, then the perifoveal ring. The central foveal ring covers the central 1 mm and presents you with the average foveal thickness, or what's called the central subfield thickness. Then the parafoveal ring is divided into 4 rings: inner upper, inner nasal, inner lower, and inner temporal. The perifoveal ring is then divided into 4 rings: upper outer, lower outer, nasal outer, and temporal outer. The most important ring in decision of treatment and follow-up of therapy is the central subfield ring, which is the central foveal ring. So we can use also the central thickness, which is a point extending from the highest point to the central fovea, or the point of the retinal surface to the central fovea in this scan. Again, this is the central macular thickness point at the center of the scan over the center of the fovea. It is very important also to obtain long line scans, not only in one direction but all in macular directions, because the central volumetric scan covers only a small area of the macula. It is important to see the macular periphery and all directions of the scan. If we take this patient, for example, the volumetric scan showed the presence of central cystic changes with hyperreflective contents and marked increase in the retinal thickness. The line scan shows the presence of BVD nearly all over the entire macula, which is a partial BVD, the presence of hyperreflective vitromacular interface in this area temporal to the fovea that denotes a starting retinal membrane, the presence of hard exudates adjacent to the fovea, to the disc at the nasal periphery of the macula. The fellow eye also show the presence of central cystic changes, the presence of complete BVD as denoted by line scans in all directions. It is very important for your device to provide you with true tracking of the macula and to obtain exact same location and follow-up when you are going to compare. For example, this is a baseline evaluation of the patient showing increase in the macular thickness with central involving cystic thickening. This is the follow-up scan for the patient with the thickness at this time, and the difference between both scans presented by minus, indicating that there is a decrease or reduction of thickness after treatment. On the other hand, this patient is presenting with nearly dry central macula. On follow-up, there is a starting serous elevation with recurrence of the small cystic and diffuse thickening of the macula. We have types of macular thickening, which are the diffuse spongy thickening, the focal spongy thickening, cystic thickening with serous retinal. We can divide the diffuse or small cystic thickening into 2 important types: central involving and central sparing. As we all know, central involving thickening indicates the patient needs treatment, while central sparing treatment can be halted or try laser photocoagulation if you wish. However, no need for injection in central sparing. So OCT volumetric scan is a type of scan that differentiate between central involving and central non-involving thickening. In this patient, there is a central sparing thickening. Also in this patient, there is a central sparing thickening. Again, a minimal central involving thickening and central sparing thickening. Now, if we see these patients, there is a central sparing diffuse spongy thickening central involving diffuse spongy thickening, central involving diffuse spongy thickening, again central involving diffuse spongy thickening with the addition of sensory retinal elevation with subretinal fluid. So what is a cut-off point that makes you know that there is a central involving or central sparing thickening? It is usually provided to you by the instrument. For example, some instruments like this one provide the measurement from beneath the retinal pigment epithelium to the retinal surface. So the average foveal thickness is about 300 micron. Then the parafoveal ring 350 and perifovea is 300 again. Other instruments provide their measurement above the retinal pigment epithelium, so it will be lesser by about 50 micron with foveal thickness of about 250, parafovea 300 and perifovea 250 again. So it is very important to know your database and the instrument you. A central involving cystic thickening, as we can see in this patient with large cysts. Central involving cystic thickening with small cysts, but we have serous retinal fluid in the subsensory space. Many hard exudate represented with hyperreflective dots in here. Another patient with central involving cystic thickening, foveal serous elevation, and dense hard exudation approaching the central fovea. Patient with small sensory retinal elevation, central involving cystic thickening, few hard exudate and hyperreflective foci, central involving cystic thickening, few hard exudation and few hard exudation and hyper. A very important player in diabetic retinopathy is the vitreomacular interface. Why? Because it can give you a guide about the prognosis of the disease. Once you have a significant vitreomacular interface abnormalities, you are facing a problem and poor prognosis. In this patient, it is very nice case with early diabetic retinopathy, and as we can see here, the posterior hyaloid is in place, not detached. A good news and a bad one. A good news because there is no vitreomacular interface abnormalities. However, the bad news, we don't know what the future carries. Another patient with partial PVD, residual adhesion centrally. Hopefully, it will return into complete PVD soon. Another patient with a lucky one with complete PVD. However, as PVD occurs, don't give 100% assurance to the patient that there is no vitreomacular interface abnormalities going to occur. Sometimes after PVD, even residual layer from the cortical vitreous remains on the retinal surface and proliferate to form a brain. Now, as we can see, this is a patient with no vitreomacular interface abnormalities, a lucky one. However, the other patient with PVD, and I think the PVD in this patient induce vitreous hemorrhage. As you can see, the hyperreflective foci of hemorrhage anterior and posterior to the cortical vitreous, tightly adherent epiretinal membrane, inducing tangential traction on the macula. In this patient, the common question is this tangential traction the cause of the spongy thickening or the diabetic changes? The answer is simple. Look at all layers of the retina. If they are equally thickened, not only the outer plexiform layer as we see in diabetes, or not markedly the outer plexiform layer as we see in diabetes, there is a tangential thickening and not vascular thickening. As you can see, here is thickening, thickening, thickening. Also, this is a type 3 epiretinal membrane. Why? Because there is ectopic inner macular layers. So the thickening here is mainly due to epiretinal gliosis. In this patient, thickening is of a composite nature. Why? Because we have thickening in the outer plexiform layer, very evident in this area, and thickening involving all macular layers with ectopic inner macular layers. So this is a composite nature of thickening, partly vascular and partly due to traction. patient with central involving cystic thickening. However, we have a tightly adherent epiretinal membrane that exerts tangential traction over this area. Opposite nature again. Patient with vitreomacular traction, evident vitreomacular traction underlying cystic changes that are mostly due to vitreomacular traction and not due to diabetic changes. Another patient with anteroposterior traction underlying elevation of the retina, a tractional retinal detachment that is nearly threatening the central fovea, if not involving parts of the fovea yet. Another example of vitreomacular interface abnormalities is the partial or lamellar macular hole and pseudo holes. Rupture of one of the cysts with the presence of epiretinal membrane gives you the lamellar and pseudo holes that are usually existing together in the same patient. Another patient with lamellar macular hole and epiretinal membranes. Autofluorescence highlighted the presence of extensive retinal laser therapy that may be the reason for the vitreomacular interface abnormality. These are very advanced cases of vitreomacular interface abnormalities. We have epiretinal membranes, splitted posterior cortical vitreous, and tightly adherent epiretinal membranes with thickening of the entire macula, disruption of some area of the retinal surface with pseudo holes. Another cases of vitreomacular interface abnormalities inducing with the traction a tractional retinal detachment involving the macula, a tractional retinal detachment threatening the central. These are advanced cases. What about OCT angiography in diabetic patients? In OCT angiography, what happened? What happened is we took an on-face image for the fundus, then a special device was added to detect motion in the retinal blood vessels. From this motion, we can draw artificial image for the retinal blood vessels. So OCT angiography is based on the on-face image and detection of motion within the blood vessels of this on-face image. Of course, if the motion is present or slow, it will not detect it, and this is one of the disadvantages of the currently available OCT angiography. However, many advantages were obtained so far, which are the presence of two vascular complexes highlighted with the OCT angiography, not only the superficial ones that can be seen with fluorescein angiography alone. In diabetics, it is important to perform OCT angiography because most of the ischemic changes occurs in the deep vascular plexus rather than the superficial one, and it precedes it with larger ischemic changes, as you can see here in the deep vascular plexus, and no evident changes or no marked changes in the. We could detect the presence of many hyperreflective foci in the deep vascular plexus and ischemic changes. Why these hyperreflective foci? They are due to microaneurysms. The cystic spaces usually appears hypo-intense in appearance on OCT angiography. Another patient, it is evident that there is cystic changes in the right eye. The left eye is thin macula. When performing OCT angiography in the right eye that presented with cystic changes, we could see that there is marked ischemic changes involving both superficial and deep capillary plexuses. Again, a patient with nearly dry right macula and cystic changes involving the central macula in the left eye. On performing OCT angiography, a special finding was detected. At the site of the cyst, there is white, not black appearance. Why? Some interpreted that by the presence of motion within the cyst, and since the instrument is designed to detect motion, it will project it as a white appearance and not black one. In this patient, we could detect a small NVE in this area. While performing OCT angiography, the new vessels can be seen clearly, and now with the advances of OCT, it is proposed that within 10 years, all The fundus can be seen with OCT angiography, including the periphery, and no need for fluorescein angiography in the future. What about the prognosis? We need first to know that the prognosis depends not only on our treatment but also on the systemic control. A tightly controlled hemoglobin A1C is very important. It is very important to control the blood pressure, stop smoking, treat anemia, and lower any abnormal blood level. Now, if we see these patients, the first one will show you a central sparing thickening, diffuse thickening, which carries poor prognosis. The second one, central involving diffuse thickening, however with good macular architecture, carries good prognosis. Third one, less favorable prognosis because marked thickening, central involving thickening, hard exudate at the fovea, serious. Now, if the vitreomacular interface carries any problem, this is a bad prognostic finding. Presence of hard exudation. If the hard exudate didn't change the structural integrity of the macula, like in this patient, or it carries good prognosis. However, in other patients, there is change in the structural integrity of the fovea with disruption of the outer fovea, and this picture shows the presence of foveal plaques of hard exudation. The plaques mean that the outer retina has been totally disrupted and replaced with the hard exudate. In this patient, the presence of sciatic or degenerative cyst carries bad prognosis for the patient. This is a very large cyst that even if it collapses with the therapy, the prognosis will remain bad for visual improvement. Presence of vitreomacular traction, disorganization of the retina in inner, middle, and outer retinal surface, retinal structure carries bad prognosis. With the left eye, you can see there is marked ischemic changes in this eye. However, the right eye preceded it in the ischemic changes. So, OCT angiography can help you in the patient complaint. Important to know, any patient with laser therapy, previous macular laser therapy, the follow-up is definitely with OCT. You can't follow up with fluorescein angiography. Why? Because all these laser marks will give you hyperfluorescence. With fluorescein angiography will give you false positive result for the presence of leakage while it is staining. So OCT should be performed especially for this. Also, any patient with hypopigmented fundus or myopic fundus, it is very important to examine him with fluorescein, with OCT, not fluorescein, because the fluorescein cannot detect leakage with hypopigmented fundi or myopic. If the leakage or the thickening is towards the disc more than central macula or temporal macula, search for a reason at the disc. The diabetic patients are very susceptible to diabetic papillopathy occurrence, as in this patient. The presence of malignant hypertension due to renal insult inducing thickening around and in the disc rather than diabetic changes. Blue peak autofluorescence or autofluorescence generally can be applied in diabetic patient. However, it highlights only retinal changes if required. Other uses are not that markedly. Thank you.